My dear friends, in this video, I am going to discuss about the biomarkers in renal injury and try to find out that whether they are useful or not. Let us start with this case. A 64-year-old man with diabetes and hypertension undergoes elective CABG. Post-operatively, he is hemodynamically stable. But at 12 hours, his urine output falls from 0.8 mils per kg per hour to zero point 0.3 mils per kg per hour. His serum creatinine remains normal, that is at 0.9 milligram per deciliter, with the baseline was 0.8 milligrams per deciliter. The fluid status is optimized, vasopressors are not required, and no nephrotoxins has been administered. The dilemma before the ICU team is that, is this transient oliguria due to reversible hemodynamic changes, or do they indicate early phase of acute tubular injury? And two, should nephroprotective measures be escalated aggressively now, or is a closed observation sufficient so that time is available and it can be attained later too? Let us go to another case, and then collectively it will be easy to discuss the effect of biomarkers. The case 2 is a 48-year-old woman who is admitted to the ICU with severe community-acquired pneumonia and septic shock. She is intubated and on norepinephrine infusion. The initial labs show serum creatinine of 1.1 milligrams per deciliter with a baseline of 0.7 milligrams per deciliter and a urine output of 0.6 mils per kg per hour. On day 2, despite hemodynamic optimization and adequate fluid resuscitation, urine output drops to 0.2 mils per kg per hour and the lactate remains elevated. The dilemma before ICUT began is that she has received 2 doses of peptides and is due for a CECT to evaluate her condition of the empyema. The creatinine remains only mildly elevated at 1.2 milligrams per deciliter, which is not meeting the KDIGO criteria for AKI. And the clinical team must decide whether to proceed with contrast imaging, switch antibiotics, and initiate early nephrology involvement. If we carefully see both these cases, then a common question which can connect to the previous as well as to the present case is that, would an early biomarker of renal injury help guide decision making? Now we know that the KDIGO bundles rely on serum creatinine and urine output. And these KDIGO bundles apply for high-risk patients at risk of AKI based upon serum creatinine and urine output, like discontinuation of nephrotoxic agents, optimization of volume status and perfusion pressure, consideration of functional hemodynamic monitoring, monitoring of serum creatinine and urinary output, avoidance of hyperglycemia, and as well as alternatives to radio contrast agents. But once the patient reaches the stage of AKI, then the measures further depend upon the stage of AKI. In the early stage 1, it is the non-invasive diagnostic workup if it suffices, and if it doesn't, then to consider invasive diagnostic workup. Stage 2, one has to consider ICU admission, RRT, and check the drugs and determine their doses. And in stage 3, to avoid subclavian catheters. Now, this is a step ladder series, but definitely in order to implement at an early stage the KDIGO bundles, the renal biomarkers can be useful. To understand their importance, the first thing is to know what are the limitations of the traditional functional markers. Since serum creatinine and BUN remain the mainstay of AKI diagnostics as per the KDIGO criteria, it also needs to be seen certain disadvantages with the use of these two. Serum creatinine rises late and is insensitive to changes in small changes in the GFR. So it will not detect the small decline that is taking place. Urine output can be affected by hemodynamic changes, by diuretics, as well as by the hydration status. And neither serum creatinine nor urine output can distinguish prerenal azotemia from intrinsic renal injury and nor identify the subclinical damage. Therefore, a lot of times the prognosis depends upon early intervention, and early intervention also based on whether it is a prerenal azotemia or intrinsic renal injury. Therefore, there has been a paradigm shift towards structural and mechanistic biomarkers that can detect kidney damage, or even if there is no damage, if the kidney is under stress, it can detect that stress even before the function of the kidney is lost. The first trial which successfully examined this was conducted during the period 2007 to 10. This was the TRIBE AKI trial, which investigated biomarkers for AKI in both pediatric and adult populations after cardiac surgery. The urinary interleukin 18 and NGAL was found to rise within hours of surgery, preceding the rise in serum creatinine, and were able to predict severe AKI. This helped stratify patients by risk for severe AKI and long-term mortality beyond clinical factors alone. Patients with elevated urinary biomarkers but without elevated serum creatinine still faced increased mortality. So it was very easy, and because if the markers can be found in the urine sample, there was no need to collect blood and check for serum creatinine. But it was also found that no single biomarker achieved the diagnostic sensitivity and specificity of traditional tests. So they were useful in combination and not in silos. So elevated post-operative tubular injury markers, particularly combined with serum creatinine elevations, were associated with higher risk of long-term mortality. Now, this path, the direction which was shown by the TRIBE AKI trial, was subsequently followed by many other trials in different settings, in smaller numbers, and a good number of meta-analyses also were conducted, although the results were not unequivocal, and certain differences in their studies were responsible for those differences in their findings as well. But till lately, we came across two good trials. These were the Topaz trial and the Sapphire trial, which almost very specifically demonstrated the utility and the benefit of these biomarkers in a large number of patients. So the Topaz and the Sapphire trial biomarkers are the urine insulin-like growth factor binding protein 7, that is IGFBP7, and tissue inhibitor of metaproteinase 2, that is the TIMF2, which were discovered to predict the near-term risk of AKI in critically ill patients. And together they are called as NephroCheck, that is available in the market. This TIMF2 and IGFB2, they are inducers of G1 cell cycle arrest, which is a key mechanism in the development of the AKI. And this TIMF2 IGFBP7 panel or the NephroCheck panel demonstrated a high ability to discriminate the risk of moderate to severe AKI. Therefore, since the other trials which followed after TRIBE AKI were largely concentrating on detecting severe AKI, these two trials were able to even moderate AKI. So delineating moderate AKI would help us to take interventional measures even earlier and thereby prevent the progression of AKI into CKD. So this panel showed significant superiority to previously described markers, and they improved the risk stratification when they were added to the clinical models. If we carefully see the nephron and we try to figure out that which marker detects injury at which site, we can see that the glomerular injury, which is often manifest late, is detected by urine albumin excretion and acanthocytes in the urinary sediment. Before that, there is change in the glomerular filtration rate and the proximal tubule function. So these are detected by serum creatinine as a measure of kinetic GFR, serum cystatin C, and serum NGAL. Even before that, if there is renal proximal tubular injury, then it is detected by urine IGF-BP7. And even before that, the distal tubule injury can be detected by urine NGAL and the urine TIMF2. So by combining nephrocheck, both proximal tubular and distal tubular injury can be identified or detected early, even when glomerular filtration has not been affected or glomerular injury is not evident. So this is the importance of the biomarkers. Now we have a lot of biomarkers and this is a tabular form which demonstrates their time to rise after injury, the type of sample which needs to be collected, the clinical utility, and the limitations, and of course, the source or the mechanism by which they are released. The NGAL, we all know, it is released from injured tubular epithelial cells and neutrophils. The time to rise after injury is 2 to 4 hours. It can be obtained from both urine as well as plasma. The clinical utility of the condition studied has largely been restricted to early AKI detection following cardiac surgery, sepsis, contrast nephropathy. It has good negative predictive value, but it remains elevated in inflammation, in CKD, in heart failure, and therefore specificity gets reduced. KIM1 is another molecule which has released by the transmembrane protein expressed by dedifferentiated proximal tubular cells. Although its time to rise after injury is slightly more than the other markers, 12 to 24 hours, it is obtained from the urine sample, but it is specific for ischemic or nephrotoxic tubular injury. And more importantly, it predicts progression to CKD. So if it is number is constant, would mean that the patient is not progressing to CKD. But the only disadvantage is that it is slower to rise than NGAL and it has limited availability. The interleukin 18 is again one of the old markers, which is a pro-inflammatory cytokine released by proximal tubular cells. It approximately rises 6 hours after the injury. It can be obtained from the urine, and it helps to distinguish ischemic AKI from prerenal azotemia and is useful particularly in post-transplant and in also septic AKI. The negative effect or the limitation is that it can be elevated in systemic inflammation like sepsis, in autoimmune disease, etc. LFABP, which is a liver type fatty acid binding protein. This is released from the cytoplasmic protein released under oxidative stress. It rises about 4 to 6 hours after renal injury. The sample, it can be seen in the urine. Clinical utility, it is an early marker of ischemic injury. The contrast-induced nephropathy detection is possible with this marker, but the limitation is that it is influenced by liver disease, other oxidative stress tests where it can be falsely elevated. The TIMF2 and the IGF-BP7, collectively called the nephrocheck, which is a cell cycle arrest biomarker, indicates G1 cell cycle arrest in the stress tubular cells. The time to rise after renal injury is within minutes, and the sample on the urine is sufficient. And this marker is useful in risk stratification for moderate to severe AKI. So before severe AKI, even in moderate AKI, it is useful and can be used to trigger the KDIGO bundles in high-risk patients. But it is limited by its high cost, limited availability, and the variation in its performance in heterogeneous population. But overall, the results have been good. With cystatin C, low protein molecular weight protein freely filtered by the glomerulus, it is also seen. It is mainly used to detect the glomerular injury and a little bit of proximal tubular injury, but its rise is later between 4 to 6 hours, and the clinical utility and limitations, those studied, are also not unequivocal. So when we have these biomarkers, it is possible for us to identify whether the patient is at low risk or high risk. If the patient is at low risk, the biomarker values will be below threshold. Patient will have stable or improving hemodynamics, no exposure to nephrotoxins, and normal urine output. So all of this qualify a patient to be clubbed as low risk. If the biomarker values are above threshold, like if the nephrocheck is more than 0.3 or NGAL is more than 150 to 200, if there is persistent oliguria despite optimization, if there is recent nephrotoxin exposure or ongoing sepsis or septic shock, or if there is a rising trend on repeated measurements, they will all constitute as high risk. So in a low risk patients, we can continue with standard monitoring serial creatinine urine output, whereas in high risk patients, we can have to initiate nephrotoxin avoidance, hemodynamic optimization, and consider nephrology consult much earlier. So this becomes possible with the application of the new novel biomarkers. So these are the four paradigms in which these novel biomarkers are useful in the context of renal injury. One is early diagnosis. Tribe AKI and the Sapphire and Topaz have shown that NGAL, KIM1, and the NephroCheck can detect AKI 24 to 48 hours before the creatinine rise. Early recognition allows preventive strategies early, like hydration, nephrotoxin avoidance, etc. And any other timely intervention can also be undertaken. Risk stratification is very important, and biomarker panels can identify high risk patients who may benefit from intensified monitoring and early nephrology consultation based on the high risk, that is, whether it is a post cardiac surgery, whether it is sepsis, whether it is major trauma, so on and so forth. Prognostication, also another paradigm where elevated biomarkers correlate with the severity of injury, need for renal replacement therapy, and long-term progression to chronic kidney disease. Persistent biomarker elevation after AKI predicts poor renal recovery. And the last paradigm is therapeutic guidance, because cell cycle arrest biomarkers like nephrocheck are used to trigger KDIGO bundles in the ICUs early, which has been associated with reduced progression of AKI and lower dialysis rates in some studies. But still, there are challenges and hurdles with these new biomarkers. One is the cost and availability, because they may not be available in all settings. The interpretation may require expertise because cutoffs will vary between population. Context-specific interpretation is required, so one gets used to it after a considerable time of use. Specificity, many biomarkers will rise with systemic inflammation or with chronic kidney disease. So it is important to exclude such factors which can call a false elevation of these biomarkers. And impact on outcomes, because the evidence that biomarker guided interventions improve or survival or reduced CKD still remains limited, and more studies, larger studies are required. So what lies in the future? Future there is of multiplex panels, which can be definitely useful by combining biomarkers like NGAL with KIM1 and NephroCheck, because they will all improve the accuracy. Integration with artificial intelligence or machine learning, because predictive algorithms incorporating biomarkers, clinical data, and electronic health records together. All those analytics could bring or to provide real-time risk scores. Theranostics, because these are the particularly imaging which has been developed. So biomarkers may be guided as targeted therapies as novel nephroprotective agents are developed, like CXCCR, and low-cost point-of-care tests, because these are very important and can be successfully implemented in resource-limited settings. So this is also a direction in which it is likely to, the future is likely to progress. So my take-home message would be that biomarkers of renal injury represent a major advancement over traditional functional markers, offering earlier detection, better risk stratification, and prognostic insights. NGAL, KIM1, and NephroCheck are among the most validated markers, and they have demonstrated clinical utility in high-risk populations. However, their routine use is limited by cost, assay availability, and uncertain impact on hard clinical outcomes like death or recovery. For now, they should be used as adjuncts to and not as replacement for the clinical judgment and standard lab values and the criteria that are followed. But however, further research can focus on integrating these biomarkers into specific care pathways. And it is only when they're integrated into care pathways, it will be possible for us to demonstrate whether their use translates into improved patient outcomes. Till that time, a little bit of positive optimism is required to use those markers, but I'm sure that definitely with time, we will be able to delineate their exact role and functions more accurately and more decisively. Thank you.